set up my clean field. So, you know, nobody's perfect with this technique. You know, I've been doing it for a while, and I'd like to say I'm pretty good with it, but that being said, you know, sometimes it's uncomfortable with it, and you have to take it out, readjust, reinsert. So we'll see what happens.
All right.
I'm going to squeeze this between you so I can get it.
Any questions while I'm setting this up?
Will this help hair grow back?
Hey, it's as good as those facial.
I want the hearing like I give up my hearing aids.
I'm just going to go with not a chance. So I'm donating the needles for this weekend. It's most cost effective for you guys. Just kind of, I'm going to have 10 packs open for you to just take one, you know, at a time, and then use that and dispose of it. Okay, but that's going to be the standard needle that we're using here. Now, swabbing the scalp, unless your head is shaved, is an exercise in futility. Good luck getting rid of the germs that are covering your hair. So,
Do the Chinese ones stuff?
no, not at all.
Think so?
Never.
Never clean anything.
No, not at all. The only times that they swab ever is when they're doing surgical procedures.
Right.
So they do have acupuncture techniques, since they're a wide open scope, like for weight loss, where they're actually using a surgical needle that's hollow and they're inserting proteins into points to stimulate it. So they'll betadine the area for that. Or they have this, once in a while they have a gigantic needle that they use at around due 9 or 8, they'll use for autoimmune skin conditions, and they thread it down the supraspinous ligament, like 5 inches, you know. And when they put it in, they betadine it, and then literally the instructor's like, you know, like shoves that down. And, you know, you would think that, like, wow, they're really skilled. I can't believe that doesn't hurt. And then you look at the patient's face, and the girl's like, and when a Chinese person's making that face, it hurts, because acupuncture is supposed to hurt, as far as they're concerned. If it doesn't ache, you get ripped off. And so, you know, that's what you would hear during the treatments. You hear, you know, from all different parts of the room, you hear this, you know, it's good chi. Whereas if it was in America, it'd be something along the lines, ow, 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 ow. You know.
So do you get that in your office?
Yeah, sometimes. It depends. Usually, I'm pretty, you know, once again, nobody's perfect, but I'm pretty good at telling the patient when it's going to hurt. You know, or I'll say, I want a strong stimulus here, so it's going to ache. Tell me when it aches. I want it to ache. You know, they're trained in the sense that if there's any sharpness that's lingering, or it feels like I'm jamming a needle into your skin, you know, after the initial insertion, let me know, because I'll adjust it. You know, but there shouldn't be any sharp stabbing pain from, like, you shouldn't be feeling like I'm jamming you with a needle after the initial poke. And so they're pretty good at letting me know when that is, and they give me a lot of feedback where things are. So, just for academic, once again, to review, to try to find our line, following the superciliary line right around to where his hairline is and or was. Do 20. I mean, I'm approximating it. It's right about here, so your line would be just in front. Okay, this is going to be your line. What this is going to be. I can do it on the other side too. Okay, so following the superciliary line around the anterior hairline, going up and down. Okay, so let's say I was treating a leg with him. You don't start right at the center for the lower extremity. You're breaking this into fifths or so. So I like to do it into thirds and then just kind of approximate it a little bit less. Just because I've been doing this for a while, but it's also a lot harder when you're holding a needle to kind of break into a third. So I would break it into half and half again, and that's going to give you a ballpark. Or if you have to pick a region, you know, what I would do is I would approximate about a fifth here, and then split the other one, and that's going to be generally, turn your head to the right, your regions there. Because this one's bigger, this one's bigger, and then that one's a little bit smaller. Straight ahead. So, when you're needling this point, I want everyone to just see what I'm doing. I'm pinching the skin just a little bit, lifting it up, just a tiny bit. You can see it if I do it here. It's the same idea. You're just lifting it up just a little bit, giving yourself some room to work with. Okay. And if you're going to do a point, you lift it up. It's about a 30 degree angle right through here, and then what you do is you start to bow it down. You're going to feel a little poke, okay? And probably some pressure. Not too bad?
Nope.
So you get it to depth. Let me know if there's any pain at all, okay? And then you start to bow.
A little bit of pain, yeah, there's some pain there. Yeah.
So, you know, and there may be some patients you're going to find their scalps are very easy to work with. Patients who have a shaved head, you know, I don't know if there's, because they get a little bit more of the sun in it, so the skin might be a little bit tougher, but sometimes there's going to be an increased correlation with that. But what you want to do is actually bow that. Are you still experiencing discomfort? A little bit?
Yeah.
So?
It's like
Can you grab me a cotton ball, please? Yeah, so we'll take it out and recess. It's okay.
No, it seems to go away, which...
Well, it's because I'm not moving it.
Right.
I'll find a point a little bit more lateral that tends to be easier. I'm just trying to go for an easy view. Once you've got this down and you're confident with what you're doing, it's not really a problem. You just find another line. Okay. So, see, not too bad, but see how it's, as soon as you walk away.
Welling up.
No, it's, yeah, you just want to keep an eye on it. Just try it again. I'm going to go a little bit farther down the waterline now. Try to go to the arm just because that tends to be a little bit easier. So I got a little bit more skin to work with. I can feel it. Same thing, just a little poke. Not too bad?
Not so bad. That's pretty good.
I don't know if there's any discomfort.
I think it's just like...
Just an ache, right?
Yeah.
But not really sure?
It's just like... the other one, you felt like a real pressure.
Yeah. So
That's
How
you,
far are you inserting that?
we'll see.
Oh.
You mean how far is it deep or how far is the needle going to move?
How far does the needle go into the tissue?
I'm threading to show you what it can be like. So right now, I'm probably about, I feel like I'm just starting to, now right now, I've been doing really well as far as getting some depth, but I just started to feel some resistance, so he might start to feel a little discomfort, so I'm going to pull that back out and kind of reassess. A little bit better. Start to feel some pressure.
Not bad. It's not bad. It's pretty good.
So you can actually see where my needle is right through here. You know, I'm starting to get a little bit of depth, probably about 3/4 of an inch.
Just slight discomfort.
More of a pressure, you're still getting some sharp.
It's very slight.
Okay.
So
So that's probably, that's a good, healthy line right there.
It is true, it's easy to see on your head.
Yep.
Ooh.
Okay. So that's going to be,
Twitching your jaw. Yeah.
It's not the needle.
he's keeping himself distracted. Yeah, exactly. See that commercial when the guy is on the computer, brain surgeon? Yeah. So the technique for this, yeah, it's just like chiropractic. You're practicing adjustment. Thank you for donating your body to science.
Sure.
But the technique for this is once you've gotten to depth and you're not in a place where there's a lot of resistance, so you've gotten to where you want to be, but you haven't come up against resistance. The needle's still free. This is where you're going to be, and you're going to stimulate it really quickly. Doing okay?
Yep.
No pain, right?
Okay.
So this is how this is going to apply. Okay, at a speed of about 200 times a minute, which is, in a nutshell, as fast as you can move your finger comfortably without causing any discomfort. But you see how nothing's moving? For those of you that can't see, except for my second finger, my index. It's the only thing that's moving. Hand's not moving. The only thing that's moving is that. My hands are firmly anchored in the scalp. Okay? So you got to get used to having that little motion with that finger moving quickly. There's nothing wrong with doing this at the beginning. I use both hands at the same time now. If I'm hitting both sides of the line, I'll just sit there and just twitch both of them.
For how long again?
It's about 2 to 3 minutes is what I'll do. You know, the indication says 3 to 5 somewhere in there, but I'm definitely 2 to 3.
So a timer or something?
Yeah, yeah, exactly. Till you think they're done. If it's a line where they're going to get an immediate response, once they've received it, I'll still hold it for about a minute or two, and then move on. The rest of the needling is really quick, and you never do, like when I'm doing a scalp needle, I'm never doing more than 2 at a time in tandem with some other point. So it's not like you're sitting there for 10 minutes putting needles in. That one takes a little bit of time, and then once it's in, I can move to the other ones, put them in really quickly. And I don't do a high needle count treatment with this. You know, I pick a few points based on what my other protocol is. You know, if I'm doing scalp and I want the patient actively moving, I'm not going to be putting needles in the extremity that I want them to move that day. So I might be doing this in auricular, and I'll have the patient writing the alphabet with their foot if they've got a denervation pattern, so that they actively
That would you
moving.
be treating as right leg?
Yeah, right now I'm a little past the leg, so I'm kind of, this is just for showing you, kind of getting to the area where I'm getting into the upper extremity for the right side. So, you know, but you're getting the general idea. Okay? Any questions on that? Yes?
You said you don't needle the same points over and over again. If you have someone who's like, I have a friend with Parkinson's.
Sure.
Would it be appropriate to do like the tremor line one day and then the motor line another, or like the vertigo, you know, do scalp?
Yes,
needling
yeah,
Saturday,
the whole,
but you know, over different days.
Yeah, you don't want to hit this. I mean, if you're going to be doing a long-term treatment with a patient, you don't want to be hitting the same points day after day after day.
Right.
Once a week is fine.
Okay.
Once a week is fine. You're
So
not going to wear it out.
One time a week you do
I'll
tremor
do-
line. Next time you do the vertigo. Okay.
Yep. And so what I do when I document that is that I'll just, during the initial intake, you know, unless there's a change in it, I'll do treatment. I'll write down treatment A, treatment B, treatment C, what I'm doing, and then I'll just, you know, day 2 is treatment B, day 3 is treatment C, and then I'll bring it back around if they're doing 3 days a week. Yeah. Or if they're, you know, if one day I cannot get a scalp needle in for whatever reason that day, because it does happen. Just not going to work. Some patients have tough scalps. Some of them are like butter. You can throw a sledgehammer in there and nobody cares. But if a patient has a really tough scalp and it's just very uncomfortable, I'm not going to do that day. I'm not going to put them, or I'll just do the other side as best I can. Which brings me to the other point. This is typically contralateral, but with face I tend to do IPSI, and that's because the cranial nerves don't cross the same way. That's me following my knowledge. The treatment says that you do contralateral for everything, but you know, especially for face, I do IPSI or both, and I'll often do both. Period, because there's decussation, but not everything is perfectly like that. You're getting some overlap. Okay. All right. I'm gonna take it. Thank you. So, anyone want to watch his head bleed? So hold the needle here when you're taking this one out. Okay, and then you're going to be putting pressure there for. Okay, it's just like the orbit or anywhere else. You just avoid the problem. I missed one a couple days ago, and she has white hair, and I didn't notice it until I had a 4-inch streak of blood going down the back of her head. It does happen. You know, you just can't see it, and so I look and I'm like, so then. Yeah, I just let her. I go, oh, this one leaked a little bit. You make a joke out of it. Not a big deal. They don't notice. It's not like it hurts. Put a glove on, grab your alcohol swab, and swab the area, and just get it out so that the alcohol swab will take out the color so that she's not walking out with a dye job.
How long is the treatment? You're going to be moving for 3 minutes?
Once I do the stimulation, and no, once the needles are stimulated, I let them retain. And then I'll give them a quick stim before I take them out. Yeah. But I needle 30 minutes.
You leave it for 28.8 minutes, or you leave it?
I needle it, yeah. My dad's 28.8. I say no less than 28. If it's more, that's fine. If it's 30, 32.
So you put the electric stimulation and then just
Yes. If it's microcurrent in the scalp, I really won't have to check on them as much because that's not going to cause any microfasciculations. It shouldn't pop out. If I'm doing millicurrent on an extremity, if I'm stimulating a nerve, then I have to
check. So what do you do? Just turn it down?
No, I bring it up to either a mild or a medium sensory level stim. So either to the point that they just first feel it, or that they can handle a little bit more. I juice it up just a little bit, but I don't want there to be any pain. But
If they're having problems, so you turn it down or just take them out?
you mean if they're having problems if it hurts, or problems if the needle won't stick?
Pain or stuff, or just.
They shouldn't. They should not be having pain during any treatment, during the needle stem.
But when you come back to check, you're checking for.
I'm checking to make sure they didn't throw a needle.
Oh, that's right.
Yeah, because with stem, see, you're fine. Now that could have easily, if I walked away, that would start gushing. I guarantee it. It's just as soon as you walk away, they start going. You're all set. Thank you. Yeah, I don't. With e-stim, it's more because if I walk out and as a needle starts to pull out, it will start to feel sharp. So the patient will notice a little bit of discomfort as the needle's getting ready to come out.
If they come out, you put it back again?
Yeah, almost always.
Sorry.
Yeah, but if they've thrown a needle, I'll usually put in a bigger needle. Because if they threw it, it's either because I didn't put it to a point that it's not going to come out, or that needle is so fine. I think the sterins are coated, in a way so that they have very little resistance. So any kind of squeezing can easily push that out. I mean, the ears, they fall out of ears all the time. So use a bigger needle. It doesn't hurt that. Like, they're getting stim there, so they're getting active sensation anyways. Like, the amount of discomfort, for this kind of a protocol is typically pretty minimal, because usually when you're doing it, they're either in pain anyways, or they can't feel as well where you're putting the needle. So, we tend to baby our patients a little bit in the United States as far as needle strength, and I'm just as guilty. I mean, I probably use sterins as a general rule more often than Amber does. But with stem, you got to use a needle that's not going to fall out, as best you can. I almost never stim sterins, because and it's not even, it's just because you're asking for it to pop out. Okay. All right. Let's see. Why don't I move this clean field to a table, just kind of a central table, or where everyone can have access to? I don't want a lot of people with needles at a time, so if we can be in slightly bigger groups, like I said, of 4 or 5 with people taking turns, that just decreases the likelihood of an accidental stick, because I should have stuff. I wanted to just bring up the homunculus here, just to kind of give you an idea. Now this isn't just sensory, it says sensory line, but this is more just the region where things are affected. So if you're going all the way to the bottom of the associated cortex, motor sensory, you're going to get tongue and swallowing, and then significant region, those 2 bits is going to be the face area. Okay? Coming back up, next 2 bits, and you'll be getting the upper extremity primarily, and then trunk to lower extremities, the very top aspect. Now, I'm going to fold over, yes, that's a little bit of the toes. It's hard to get, they say that the most inner aspect, but as far as the treatment principle is concerned, you're getting the lower extremity when you're getting the upper one dip. Okay? Good image.
So when you put a needle on an ankle, you're actually hitting several points then.
Yeah, it's just region.
This region.
Yeah.
Just the whole region.
Yeah, for this style of needling, it's not like this part is arm. It's just, you got to treat it as upper extremity. Which the wiring's a little different from person to person. Do you have a question?
I was going to ask if you want to differentiate shoulder to hand, the way that's set up. It's more like this, upside down. But you just said it doesn't really matter. You're doing the whole.
Oh no, yeah. That being said, yeah, it's a region. So, if you're trying to get the hand, yes, you should probably be towards the bottom of that region. That's okay. I tend to, I definitely will reference it when I'm going right after an area, because I have a couple pictures of these in my office stuff. Those homunculus just to kind of help reference it. But typically. I try to stay in the same area when I do it, from week to week, and then check the clinical evidence. Sooner than not, they're either getting better or they're not. You're going to find out whether you're in the right place. I really like to, and Kathy touched on this really briefly, which was a good idea. I don't do this as much typically, because I tend to just go for my threading. If you're not comfortable with threading initially, I was saying that you're only supposed to do 1 needle per region, so 2 per side. It is okay to do 3, like through that area. If you can't get the depth that you want, the skill is just not quite there, you know, to do 2 for that region, we'll start at the top, start in the middle, you know, something like that, to cover your bases. You know, it's just, you gotta weigh your clinical outcomes and what you wanna do with that at the beginning. And then as you become more confident with where the needles are going, you can drop it down to 1. But there's nothing wrong with less depth and more needles as far as getting the region. It's always better to try to do more with less. You know, and so as your skills as a provider evolve, you want to use less and less and less.
So if you're trying to treat the whole body, you can take one big, great, big long needle and
Just thread the whole thing. Become Hellraiser. He's totally zen. I mean, just Hellraiser's totally zen.
Do 2 at once.
Yeah. All right. So we're gonna jump right from the motor line now into the sensory line, and we'll give a quick little overview of this. Right? So sensory is just like the motor as far as the layout. You know, face, arm, head over the top, or leg over the top. It's just that you're treating pain or lack of sensation. You know, and you're just hitting that region. So the upper 1/5 is going to treat pain or numbness of the contralateral lower limb. However, it also does target occipital headache. There are some exceptions here where they find that it can be a little bit more effective. Stiff neck, that kind of thing. Middle 2/5, pain, numbness of the contralateral upper limb. And lower 2/5, treat facial migraine, headaches, trigeminal neuralgia, toothache. So remember, the lower 2/5 for the motor side was you could use for Bell's palsy or something to that effect. Sensory side, trigeminal neuralgia, something to that effect. Has anyone ever seen a patient with that or had it themselves? I had a trigeminal neuralgia.
Oh, yeah.
I had a transient case of it. I wanted to stab my eyes out, but it was really quite horrific. That was when I was on spring break in Florida. I had transient trigeminal neuralgia. I made the mistake of realizing that I was like 19.
Is that the Aleve?
Yeah, that was the Aleve event.
Yeah.
Yeah, I thought Aleve and Advil were equivalent, so I took 4 of them.
Wasn't very alleviating.
You know, I almost went to the hospital because I was definitely vomiting blood. It was not a good time. Almost went to the hospital. Did not. So sensory line is really, it's a great point. A great line that we use. I use it just as much as I do motor. It's second most common one that I use. You know, motor being the first, and then probably the tremolo line being the third. This one you don't. I'm not going to say that you're going to get instant gratification like you do with the tremor line, but you tend to. You'll see things that are pretty cool in clinical practice if you're in the right area with somebody that, you know, when you're working the area. You know, if you're on the sensory line, even during this right here, you might be hitting the area the patient may be feeling. The person getting the needle may be feeling something somewhere on their body from that could correspond to it. I often, when I'm working with patients that have sensory loss in their lower extremities, this is one when I'm going after it, right at the top, they'll feel it. They'll know.
How much distance between this and the motor line?
So it's 1.5 soon behind the motor line. I'm sorry if I didn't touch that face. Sensory line. 1.5 soon behind the motor line. So we're talking from person to person, it's less than an inch. It's just about an inch behind them, as far as like the imperial inch. Body inches soon 1.5. Obviously, that's proportionate from person to person, but you know, just over a little thumb width behind it. Yeah. Okay. So, like I said, you guys are going to be leaving here tomorrow, being able to do this. So let's do it. Sensory line. Do you want me to show this one, or can we just jump into it? You want to see? Jump into it?
Well, maybe you could just.
Show one person. Well, why don't we have a person sit and I'll just demonstrate how to find it, and then I'll let you guys break loose. Yeah. Okay. So I need one person to come here.
Oh, the bald head.
Yeah. I'll take the shaved head.
I was gonna say, you'll be able to see better.
You could draw lines on
That's true. You could tattoo.
You know, that was one of the big. I did that on when I was in school. One of the things that we did was take one of those styrofoam heads that they use in like beauty school, and we marked all of it up, and I took all the acupuncture points and did that on the head, and they really did look like Hellraiser for that. So, just to review, you got your A to P line, one that follows the sagittal suture, okay? Then you take, I'm just going to approximate U20, with him is about there, so you're just in front of it. And you take the superciliary line, find out right where the hair would end, right about there. This is my motor line, right through here, right? Okay. I'm going to move about a 1.5 back, I want to be very specific about it. You could approximate the 6. 1.5 do. So, motor line is going to be running like this. Okay. Sensory line is pretty much, like I said, it's about an inch, a little less than an inch behind it, and it parallels it. Okay. It doesn't come to that landmark. It's 1 inch behind it, so it's going to be much farther back. Not quite to the parietal eminence. Okay, that's a different line. So you're going to be just about an inch or so behind the motor line, parallel to it, and you're going to cross the parietal eminence about an inch in front of it, somewhere in there. That should give you a good landmark. Okay. That being said, people's heads are shaped differently, so I'll have to come over and take a look at it. But that's where you should start. Why don't we start with the upper fifth and work our way down? Okay. Or maybe we should start nicer since it's been lunch. Why don't we work our way up? We'll do the lower ones because there's more flesh here, tends to be more comfortable, and then we'll start working our way up. Okay? But you still needle these down. All of them are needled down unless you're, particularly adept at going up. Okay? When I'm managing a patient that's got like a windy condition, you want to treat both the root and the branch, meaning that you're treating the symptoms as well as the constitution that's causing it. And so this gives you a very powerful tool to help kind of help extinguish the wind from the area that's being affected, those tremors, whatever that may be. This is one of my top 3 favorite places to needle because it's instant gratification. This is a good point. You know you're in the right area because I would probably say 3/4 of the time, 80% of the time, you see an improvement immediately with your stimulation. You'll notice that the tremors start to decrease, the eye twitches start to decrease, and the patient will notice it. You even tell them, I'm going to put a point in. That's usually it has a functional improvement immediately. So let's see what happens there. Don't be disappointed if it doesn't, but it does occur. And so, I hear responses from my patients saying that's nothing short of amazing. And that's the push button effect. That she wanted me to put stickers there so that she could show people if you stimulated it, because even her stimulating that one would cause it to decrease. It's a really good one. I'm not treatment duration is proportional to visit frequency. If you're doing it once a week or once a couple of weeks, the benefits are going to be transient at best. I don't know how long it will last. It depends on what else you're doing to address it. The patient with the tics that I was talking about, I've seen her twice a week. It's been about 6 or 7 weeks, and I've got about an 80 to 90% reduction. I am using herbs at the same time, but it works really well. So this line is the exact opposite as the sensory. So we had our motor line, sensory line was 1.5 cm behind it. The line of Corrigan tremor is 1.5 cm in front of the motor line. Okay, there's no regions on this. It's not that there's an upper, lower, or whatever. It's just one. The line's a little bit shorter, but that involves more threading. It's still a good-sized region. We're talking about a 3-inch region. So I would usually start about an inch off of the dew, and then just start threading it down. And this is one that you have to do either millicurrent or microcurrent or stimulate to get an effect. You can't just put the needle in and expect it to go away. I stimulate the hell out of it. Okay.
So typically one needle?
Yes. With it, once again, we touched on this just briefly. If you need to get more parts of a line and you can't thread it, and you've tried a couple times, there's nothing wrong with putting a second needle to get treatment in that area. That being said, I really only use 1 needle per side. I do treat this almost always bilaterally, especially if it's in the face. Okay.
Because there's only 1 region, not 3 regions.
There's not 3 regions. It's just that one line. They don't affect different areas. It's just a full body thing. Now, I would probably use a little bit of judgment. If it was a lower extremity, I would cheat more towards the sagittal line. If it was more in the face, I would go a little bit lower, which is what I do. Because it is a realm, but I'm covering, when I thread about an inch or so on this one, usually. Okay? Let's do it. I said you'd all have headaches.
I've done it, but just do it.
Is that from watching, or is that from?
I think it's actually from someone who received me maybe a little too hard earlier
Uh-oh.
today.
Uh-oh. Back in Cairo
Ready?
school.
Yeah.
Yeah, tomorrow is ears. So we won't be doing Oh, glasses off the too?
Oh, you need to make a lead?
Yeah, see any of it.
Hey, could you hit him? No?
Yeah. He was tough.
Relax completely. Did you hand me my check? Thank you.